So for task 6, this is going to be our monitoring anesthesia using the chart, and here we're going to just talk about the different planes and the different stages of anesthesia, vitals under anesthesia, different reflexes that are seen to help determine our stage/plane, and then how the physiological things all kind of interact and go back and forth with each other. So I'm going to start with just the physiological stuff. So our vitals, per se, heart rate and heart rhythm are the first two. Our heart rate for dogs is going to be anywhere between 50 and 180. For smaller patients, they're going to be at the higher end. For larger patients, they're going to be at the lower end. And then, of course, we always have to take into account, how they come in. Is it a naturally calm dog? They might naturally have a lower heart rate during anesthesia. Is it a really excited dog? They might have a really higher heart rate. So there's also things that we need to take in when looking at that. As far as the rhythm, we want to make sure that they have a easy, normal rhythm. So we want it to be called normal sinus rhythm. We want to make sure that our complexes are nice and equally apart. We don't want to see any different blocks, first degree, second degree block. We don't want to see any VPCs. We don't want to see any pulse deficits, anything like that, where we would have a few complexes and then a little bit of time, maybe like a first degree block and then another complex and then or second degree block for that matter. So we want to have what we like to call normal sinus rhythm. So for the next one, it's going to be a respiratory rate. We want to see our respiratory rate anywhere between 5 to 6 to about 20, again, depending on the patient. Any more than that or any less than that, our patient may be a little bit light or our patient may be too deep, depending on the stage of anesthesia. For the next one, for the respiratory rhythm, same thing with the heart rate. We want our rhythm to be nice and even. We don't want our dogs panting. We don't want them gasping. We don't want to see our little papa valves fluttering too much. That means they're taking smaller, shallower breaths, which means they're probably not oxygenating as well. So those are all things that we want to take into account. And then along with that is our temperature. So we want a normal body temperature no less than 98 degrees. Once you get below 98 degrees, you start running into blood pressure problems, perfusion problems, possibility of having more difficulty staying under anesthesia. We'll cover that more in the third section. And then for our cap refill time, that would be, we want to say that less than 2. When we have a prolonged cap refill time or greater than 2 seconds, we're also looking at poor perfusion, which is not good, can lead to organ damage, tissue damage, etc. And then mucous membranes, we always want a nice pink color. We don't want to really see them injected, and we don't really want to see them too light pink because that means also poor perfusion. So another couple ways that everything interacts together, covered in stage 3 or in the third part. In the second part, they want to talk about the different reflexes. The main ones I always look for, also depends on the stages that we're in, but the main ones that I look for are going to be my jaw tone, my palpebral reflex, and then also I like to look at the respiratory pattern and the swallow reflex. If my dog is swallowing or if they have a pedal reflex, I know that they are in probably early stage 3 to stage early stage 3, probably in the first plane, or late or in the kind of late stage 2. Stage 3 is where we always want to have our patients probably closer in the plane 2, plane 3, no more than that. So then once we're there, lost my train of thought. So with the pedal reflexes, you're going to see that in the early stages of early planes of stage 3 and the late plane of stage 2. And then eye position, that's a big one. What we want to do when a patient's awake, when they're looking forward, they have nice normal, the eyes aren't rolled down, everything's fine. Probably in later stage plane 2, you'll start, in the later stage 2, you're going to notice that the eyes will start slowly rolling down, and then your early stage 3, plane 1, plane 2, you'll notice a big increase in how much the eyes are rolled down. And what I like to look for is I like to have like a nice horizon. So when I go to open up their eyes just to check to see where their eye position is, I like to see just a bit of the cornea, so I can see, you know, exactly where their eye is. If it's rolled down too far, I know they're possibly too deep. If it's looking forward, I know that they're still awake, or they're still in an early stage. So another one to look for is the eye pattern. I don't want them breathing as a machine. I think I already talked about this. Jaw tone. I want to make sure that the jaw tone is nice and loose. I know if they have a nice relaxed jaw tone, that they're probably in plane 2 to plane 3 of stage 3. That's kind of like the perfect place where we want our patients for anesthesia, for surgery, sedation, probably 1, 2. You might have a little bit of jaw tone left still. And the corneal reflex as well. So with the corneal reflex, you're still going to get a reflex. Pupils dilate, there might not be the light reflex that we're looking for. Palpebral reflex is a wink reflex, so that disappears in the plane 1 of stage 3 into plane 2 of stage 3. And then obviously the fetal withdrawal we discussed already. So let me think what else I'm missing. Alright, so for the third part, we're going to go into kind of how everything relates to each other. And everything does have to play a part with each other. The first one, my big one that I always look at is my heart rate, and then also my blood pressure. I know that if I have a really high heart rate, I'm probably going to have a lower blood pressure because the heart is working a little bit harder to kind of to push things along. So it's having to pump faster to get good perfusion to those tissues. So what you'll notice is that how the blood pressure starts coming up with the induction, with using fluids, doing some fluid boluses, introduction of some pentastarch, what have you. You'll start noticing that the blood pressure will start creeping up, your heart rate will start creeping down, and everything will kind of normalize. This also works in opposite order, where if I have a really, really high blood pressure, I'm going to have a really low heart rate, and this is often seen with drugs like dextromethorphan. It's a vasoconstrictor, so the heart just doesn't have to work as hard, so generally you'll have that really low heart rate. Something you have to get comfortable with. Nothing you can do about it.